All right, Ellen, do you want to start or do you want me to start?
No, absolutely. I'll get started. I've just got all these people asking to be admitted. All right. So, welcome everybody. Thank you so much for joining. My name is Alan Kaplan. I'm a family physician in Aurora, and I'm the regional primary care lead of Central Region. So, I have the honor of presenting a friend and a colleague, and someone who's taught me a lot about colon cancer screening, Dr. Vishal Patel, who is our regional colon cancer lead, as well as being the medical director of cancer care at his hospital at North York. So he's going to give us an update on colon cancer check screen changes. There's been a few changes in both the program and the eligibility, and I look forward to hearing him share that with us and making these changes, which maybe sound complicated, but in fact they won't be. He's going to make it real easy. So Vishal, please go right ahead.
Thanks, Dr. Kaplan. There's a lot of information to go through. I'll try to be somewhat efficient, mostly so that we have time at the end to answer questions. And the questions will be, I think, submitted through the chat, and Dr. Kaplan can help me moderate that if you're okay with that. Okay, so this is an exciting time for us, something that is probably a long time coming, and at least I've been asked about in my practice on a fairly regular and frequent basis by patients. So I'm very happy to be discussing these changes to the colon cancer check program, essentially changes to colon cancer screening for Ontario. Just going to start with a land acknowledgement. So this is a Central Regional Cancer Program, and we're honored to provide care on the lands originally used and occupied by the First Peoples of the Williams Treaties, First Nations, and other Indigenous peoples, and we thank them for sharing this land. We would also like to acknowledge our closest Indigenous community, the Chippewas of Georgina Island, and recognize the unique relationship the Chippewas have with the lands and waters of this territory. They are the water protectors and environmental stewards of these lands, and we join them in this responsibility. In terms of my disclosures, as already mentioned, I'm the regional lead for the Central Region and represent Cancer Care Ontario. I have no other commercial interests to disclose. The program has received financial support from Ontario Health CCO in the form of payment for certification for this module. I receive funding for my role, and providing this type of educational support is one of my duties. And the content that's being presented is supported by data. I will be presenting some of that data. So there is a scientific planning committee that creates this and reviews this presentation. So if you have any concerns about bias, then you can certainly feed that back to us. The success of any screening program is purely based on how many people it can reach and convince to participate in the screening program. So when we talk about cancer screening, it's important to recognize that there are different gender identities, and gender inclusive language can help screen eligible people understand if screening is right for them. So in the context of colon cancer screening, eligibility is not dependent on gender, and so we avoid the use of gendered language in this presentation. Okay, so let's start with the discussion on colon cancer in Ontario and the important changes that will be coming up. So just a quick quiz here. Rank from highest to lowest number of cancer-related deaths diagnosed in Ontario in 2024 by type in males and females combined. So the options are breast, pancreas, colorectal, and lung. I'll just rank them here. So lung is number 1, but colorectal is number 2, and that's fairly recent. So 2024 data. If caught in stage 1, approximately what percentage of people with colorectal cancer will have survived at 5 years? 90%. So this speaks to the importance of screening and early detection. Of the people diagnosed with colon cancer in Ontario, approximately what percentage have no family history of the disease? That's C, 70%. So 70% of people diagnosed with colon cancer have no family history. So it's a common misconception that people have a family history that puts them at increased risk. Many people don't. So colon cancer accounts for 10% of all cancer deaths in Ontario. The lifetime probability of developing colon cancer is 1 in 22. It's the 4th most commonly diagnosed cancer overall in Ontario. In men, it's the 2nd most common and a 3rd most common in women. 10, as I mentioned, 10% of all cancer deaths. And when caught early, 9 out of 10 people can be cured. So this can be detected early and be curative in many cases. So the burden of colon cancer is unequal across certain population groups. And some of this is based on socio-demographic groups. Many stem from structural, systemic factors, income disparities, different education backgrounds, social supports, neighborhood disadvantages, just to name some. So we don't collect all of this data on patients, so we don't really know which ones are specific to colon cancer, but we do know that there is significant variability. We do have some data on colon cancer in the Indigenous population available. And what we know here is that the incidence rates in First Nations people in Ontario are higher than the rest of Ontario. First Nations people also have a higher mortality rate and a lower chance of survival following a diagnosis of colon cancer. In the Métis population, the incidence rates are lower for females compared to other females in Canada, which is interesting. We don't know exactly why that is. And then in the Inuit Nunavut populations, the incidence rates are higher compared to the rest of Canada. Oops, sorry. So this is an important area, again, for screening as a population that we really have not been able to properly address with screening programs, and this is sort of a high priority area for us to determine ways to improve our screening in the Indigenous populations. So let's talk about the ColonCancerCheck program. This was one of the first organized screening programs. It was launched in 2008. And really, it's an organized program, population-based screening, sends letters to eligible people. The goal is really to reduce people's risk of developing colon cancer or subsequently dying from it if they do, or if they are diagnosed with it. And the best way to do this is increasing screening for the screen eligible population. There are 2 methods to screen. For average risk patients, it's the FIT test, and for increased risk patients that are increased risk, it's colonoscopy. So we have, as mentioned, this is a population-based organized screening program. The other way to do this is opportunistic screening, which really puts the onus on the patient or the primary care physician to initiate screening. In an organized screening program, this is run centrally. There are clear policies and processes to access or educate the population that we're targeting. This is all based on scientific evidence and data. for the and then there's tracking and monitoring and performance checks and quality improvement to ensure that we are achieving the outcomes that we are trying to achieve. And if we're not, then opportunities to improve that. So for ColonCancerCheck, we definitely have a common and burdensome disease. There is a detectable preclinical phase. There is a defined population in terms of the test or intervention. This is primarily the FIT test, so it's a very acceptable and accurate test, very safe and easy to implement and acceptable to patients. And then we have a supportive structured program to monitor our data and perform quality improvement and performance management as needed. So basically maximize benefits and minimize harms. Okay, so let's get on to the changes. So as of July 1st, 2026, so some of these changes are not yet posted on the ColonCancerCheck website, but they will be as of July 1st, 2026. The screening age, which is currently 50 for average risk, is going to be lowered to 45. There is updated eligibility criteria for both average risk, as mentioned, and increased risk patients. There is a new laboratory and device vendor for the FIT test and some process enhancement, which we will go into detail. So the purple are the text in purple are the changes. Currently, average risk for the FIT test is recommended between ages of 50 to 74. That's going to change to 45 to 74. Average risk is defined by patients who have no personal history of colon cancer or precancerous polyps that need surveillance, or inflammatory bowel disease such as Crohn's colitis or ulcerative colitis. Patients that do not have a high-risk family history. So that would mean any of these types of family history. So a first-degree relative diagnosed with colon cancer that is 60 or older, or first-degree relatives diagnosed with polyps, or one or more second-degree relatives diagnosed with colon cancer or polyps at any age. So these are all considered patients that are considered average risk and would be under the FIT screening protocol. The increased risk patients are different. So essentially, those patients are patients that have a family history, a first-degree relative diagnosed with colon cancer before the age of 60, or two or more first-degree relatives diagnosed with colon cancer at any age. So these patients would not be candidates for FIT. They should go directly to colonoscopy and start at age 40 or 10 years before the lowest age of diagnosis in their relatives. Additional important requirements which have not changed, but include that the patients must have OHIP coverage, be asymptomatic, obviously be due for screening. So due for screening means patients that have had no previous screening or a FIT test that was done more than 2 years prior, or a high quality colonoscopy that was done more than 10 years prior. We will talk about surveillance and some patients that have had colonoscopy with low risk findings are eligible to be in the FIT surveillance program rather than having to go through another colonoscopy. Screening is not appropriate for people with symptoms, so it's not a diagnostic workup. For things like iron deficiency anemia, rectal mass, rectal bleeding, weight loss, abdominal pain, change in bowel habits, the FIT test is not validated as a diagnostic test in these settings, and if appropriate, then patients should be referred for investigations such as colonoscopy. So there is data and evidence to support these changes. So firstly, for lowering the age, as mentioned, it is being lowered from 50, the starting age, to 45 in average risk patients, and in patients with increased risk. The recommendation was to start at 50, and now it's to start at 40, or as mentioned, 10 years earlier than the age of the youngest relative that was diagnosed. So there are, in terms of evidence, there's epidemiologic trends in the distribution of colon cancer. There's a birth cohort effect that have shown that there's an increase in colon cancer incidence and mortality in people under the age of 50. This is all published. We also have modeling that's been conducted specifically for Ontario that demonstrates the positive impact of lowering the screening start age. And then, of course, this was all reviewed and discussed with an expert panel to confirm these recommendations and proposals to lower the start screening age. So in terms of the changing epidemiology, this has been, actually been publicized fairly regularly. But in the last 10 years, what we see is that the incidence of early onset colon cancer, so patients that were under the age of 50, has increased, whereas in adults older than the age of 50, the incidence has actually decreased. And what that shows is that the screening programs have had an impact. So the screening programs have started at the age of 50, and so that's why we're seeing that impact in that age category, but not in the younger patients. Even though there is an increase in the younger onset colon cancer, it's important to note that the overall numbers still remain low compared to the older patients. When you look at the incidence rate for colon cancer over time across generations, there is a birth cohort effect. So compared to people born in the 1950s, people born after 1980 have higher rates of colon cancer. So this suggests there is some impact early on in life that is contributing to the development or increasing the risk of developing colon cancer. We don't exactly know what it is, but there's definitely been a change here. In terms of this graph here, so this is comparing incidence of colon cancer across different age categories. So the red, which is a third from the bottom, and the orange line, which is the second from the bottom, you can see that there's been a slight increase in the incidence. So the red line is people aged 45 to 49, and the orange line is just below that, so people aged 40 to 44. And if you look at the older patients, the green lines, there's an overall trend that the lines are actually going down, whereas that red line is slightly increased. You know, the third line from the top, the lighter green one, the people aged 50 to 54, there is a little bit of a spike at the end. And what I would say to that is that, that probably is also reflecting the fact that those people weren't screened until they were 50. So again, probably a group that would benefit from screening starting at age 45. In First Nations people, compared to other people from Ontario, there is a higher incidence of colon cancer and slightly more likely to get colon cancer at a younger age. So lowering the start age will hopefully contribute to an improvement in this population as well. In terms of Ontario modeling, so this would be how we think that the changes are going to impact our population. So this suggests that there is a benefit in terms of 50,000 person years of life gained, 11,000 fewer cases of colon cancer, and the subsequent resource utilization associated with diagnosing, staging, and treating those patients, and probably 4,000 fewer deaths. So significant impact expected from lowering the screening age here. So starting July 1st, for the primary care team on the line here, you're going to be able to start screening patients 45 to 49. There will be invitation letters sent that will be phased in over a 2-year period for this group. But people can start screening as of July 1st, even if they have not received an invitation letter. And then also the increased risk patients can start screening for direct to colonoscopy starting at age 40 or 10 years earlier than the age of diagnosis of the youngest relative as well, starting July 1st. Specifically for the family history now, there has been some changes, not too many, but I just wanted to go over them. Again, purple represents the change. So currently, average risk was defined with patients with no first-degree relatives diagnosed with colon cancer, more than one first-degree relative diagnosed with colon polyps, or more than one second-degree relative diagnosed with colon cancer or polyps at any age. So the only change is that this has been further detailed down. So if a patient has a first-degree relative diagnosed with colon cancer that was over the age of 60 or older, then they would still be considered average risk. Whereas patients who have a first-degree relative that was diagnosed with colon cancer at an age less than 60, or 2 first-degree relatives diagnosed at any age, specifically both for colon cancer, they are considered increased risk. Again, this is evidence-based. There is data to support this. And all of you will be going through that here in a second here. So this is the data supporting or showing the absolute risk of developing colon cancer by age 85, depending on, based on family history compared to the general population. And these are looking at two populations. One is the European population and the other is the US population. So what you see here is that there appears to be an absolute risk of developing colon cancer by age 85, which is about 1% higher than the risk in the general population, but this was not statistically significant, and the confidence intervals were wide, quite wide. So this does not seem to be a significant difference. When you further separate this population with the family history, what you start to see is that first-degree relatives that were diagnosed less than 60, there is a significant increase in the risk of colon cancer, both in the European and the US population. These are statistically significant differences, and the confidence intervals are narrower. And that gets even more pronounced when the first-degree relative was diagnosed at an age younger than 50. So that's where this recommendation for an increased risk in family history comes from. So the reason FIT is recommended over colonoscopy, generally colonoscopy is an invasive procedure. However, it is generally safe and accurate at detecting colon cancer and polyps. But there is some burden on the patients. It's a procedure. It does require sedation. It does require bowel preparation. When you look at the evidence from this large randomized controlled trial, which was a non-inferiority trial in Spain, looking at colon cancer mortality, comparing one-time colonoscopy versus a FIT test every 2 years. The study demonstrated that people who were offered screening with FIT had higher participation rates. So more people were willing to undergo screening in the FIT group compared to the colonoscopy group. And again, a screening program will only be successful if participants actually, or if patients actually participate in the program. And so in this study, the FIT was comparable to colonoscopy in detecting colon cancer and in reducing colon cancer-related mortality. So the FIT patients, obviously fewer people needed a colonoscopy to find the same number of cancers, which made the colonoscopy more high yield. So when you compare colonoscopies in all patients, all average risk patients versus colonoscopy in the FIT positive patients, what you find is that there's fewer normal colonoscopies or negative colonoscopies and more significant findings that are intervened. So the colonoscopy becomes much more high yield when streamlined by FIT testing. So we just talked about this, but again, patients with first degree relative diagnosed with colon cancer at an age younger than 60, or two first degree relatives diagnosed with colon cancer at any age, are considered higher risk and should go directly to colonoscopy. In terms of screening intervals, this has not changed in terms of the average risk. So if a patient has a FIT test and is negative, then the interval for the next FIT test would be 2 years. For people with increased risk of colon cancer, so if they're going to undergo a colonoscopy, and then the interval for the colonoscopy would be 5 years. In terms of when to stop screening, so the programmatic or population-wide screening stops at age 74. This has not changed for the average risk. For the increased risk, again, the recommendation is to stop at 74. And really, the reason for this is that as the patient gets older, over the age of 75, the benefits start to go down and the risks either are the same or start to increase slightly. It does not mean that patients over the age of 74 cannot be screened. What it means is that this requires a discussion with the patient, assessment of risks and benefits. And FITs can be accepted or requested up until age 84. People over the age of 85 really should not be in screening because of the limited benefit. In terms of other changes, so the device vendor has changed. The contracts with the previous lab and FIT device expired and they had to be reissued. So this was done by Ontario Health and Cancer Care Ontario. So Micronostics is the FIT device vendor, and In Common Laboratories is the laboratory service provider. The ICL labs are Canadian not-for-profit lab. As a result of these changes, the FIT requisition is going to change as well. And again, this will be available starting July 1st. These requisitions will now need to be faxed or sent to In Common Laboratories instead of the Life Labs as done previously. There are some practical changes that you need to be aware of. So you need to have an account with In Common Labs to get FIT results. And if you submitted a requisition for FIT to Life Labs within the past 2 years, then ICL will be able to set up your account automatically. there may be some missing information that they may need to verify. If you have not submitted a FIT requisition to Life Labs within the past 2 years, then ICL will need to create an account for you for the first time you submit a FIT requisition. The account setup is required for every working address or location that you work out of. If you practice in multiple sites or use multiple fax numbers or work as a locum, you need a separate account for each of those. And as part of the account setup, you will need to verify your fax number, specifically if you have not ordered a FIT with Life Labs within the past 2 years, or if ICL had to contact you to verify the details. And this is only a one-time process. It's fairly quick. And again, if you have multiple fax numbers, you need to do this for all of them. So this is also important. All the FIT results will be available through OLIS, but you also have to have a direct reporting method. And right now, fax is the default method. The other direct options, EMRs, with provider query functionality or mail, you need to actually request that it be sent by mail to the to ICL's FIT support team. And just so you know, ICL will still process requisitions and complete FIT tests, even if your fax verification is pending. You just will not be able to receive the fax reports, but you can still look them up on OLIS. We are aware that the EMR, direct EMR functionality is yet still pending. So Ontario Health is working with Ontario MD certified EMRs to make the FIT results directly available to EMRs. That's not necessarily going to be available for all EMRs on July 1st, but we are hoping that that will be addressed very soon. And you can go to this website here, iclabs.ca/fit/reports, to indicate which EMR you use. So this can be automatically switched from fax to EMR once that feature is set up for your EMR. In terms of the FIT device itself, although the device has changed, there's not much change in terms of the size. The cap is a twist to close instead of a snap-on, which is hopefully an improvement to reduce the problem of leakage that was happening previously. Instructions are now available in 30+ languages, and this will all be available on the FIT instructions and ColonCancerCheck Hub website. So in terms of ordering, so until June 30th, 2026, you will be doing the exact same thing as you've been doing. So ordering through Life Labs, using the Life Labs FIT requisition. Do not send any FIT requisitions to ICL, as they will not be processed. After July 1st, you will send all new or replacement FIT kit requests to ICL using the new ICL FIT requisition. Do not send any FIT requisitions to Life Labs. For patients that have the FIT kit from Life Labs for a test that was ordered before July 1st but have not yet returned it, they will still be able to return the Life Lab kit to Life Labs as per the usual method, and this is ongoing for at least a year to support the transition. So there should be no issues with FIT tests, Life Lab FIT tests that were ordered prior to June 30th that have not yet been completed. After July 1st, 2027, no FIT kits will be returned to Life Labs. They will be rejected, and all tests will need to be ordered through ICL. If a FIT test is rejected due to a rejected device or invalid result, a new requisition will no longer be required. The FIT kit, a new FIT kit will be sent directly to the patient. So that should hopefully reduce some of the administrative burden for you. There will also be a reminder letter sent to patients that have had a FIT kit ordered and sent but have not yet returned it. And there are a number of resources for both primary care and patients. In terms of patients, again, as mentioned, they will have they will receive letters from ColonCancerCheck for inviting them to participate in screening, reminders to participate in screening if they have not yet completed it. They will receive the results. And then there will be a new reminder letter for people who were mailed a FIT kit but have not completed or returned it after 2 months. So we're hoping that these changes will lead to increased participation in the screening program. One of the things that that the data supports is that patients are more likely to participate in screening if they receive a letter or reminder that is linked to their physician or has their family physician's name on it. And so there is this opportunity to participate in a physician-linked correspondence. If you would like to have more information or sign up for this, then the website is listed below. We are trying to add these websites in the chat for your reference, but they will also be sent out to you afterwards. Again, there is a reminder letter that will be mailed out to patients who have received a FIT kit but not returned it for at least 2 months. And again, there's some information on colon cancer screening and motivational messaging as part of that letter to hopefully improve compliance with participation. There's also a fact sheet for colon cancer check and screening available for patients. Again, this will be available in a total of at least 30 languages and available on the Colon Cancer Check Hub for you to provide to your patients as part of the education for screening. This has not changed, but unattached patients are eligible to receive FIT tests this is self-initiation. They or someone on their behalf can call Health 811 and request a FIT kit. If they end up having an abnormal FIT test or need a colonoscopy, then Ontario Health or CCO will assist in providing them with a way to be referred for a colonoscopy. And if there's ever any issues with access, then I'm happy to receive information and assist in arranging that or connecting them with one of our facilities in the region.
If I can just jump in there for a second, Vishal,
Sure.
please. So right now, anybody who's not connected to a clinician, the program usually reaches out to me to look at them, which is fine, and I deal with the test and refer them on. If any of you, however, are looking to grow your practice in any way, and you're interested in being one of the people who will then see these unattached participants, please let us know. You can reach out to me personally. I'll put my email in the chat. Because we're looking for people who are interested in following up on unattached patients for colon cancer screening and other cancer screenings as well. Sorry to interrupt.
Yep, no problem. Thank you. In terms of resources for all of you, again, the Colon Cancer Check Hub is an excellent resource, lots of information there, FIT requisition, instructions, questions, all the guidelines, including the changes that we will be discussing today. Some of that will be updated for July 1st and to incorporate all of these changes that we are discussing today. There is also this registration option for a screening activity report. So by signing up for this screening activity report, you can sort of help yourself identify screen eligible patients and monitor FIT results that may require follow-up. So the SAR is a report on patients who are overdue for screening, had a normal FIT, or had an abnormal FIT, or have had a colonoscopy. And this can be accessed through the My Practice Primary Care Plus report using your OneID credentials. So there is the URL there at the bottom that you can use to help you identify patients that may be eligible for screening and need to be contacted. And then there is we just wanted to let you know about this course for Ontario Health's Indigenous Relationship and Cultural Awareness, a self-paced online course. Lots of Main Pro Plus credits available. So if you're interested, you can participate in this. And here's some contact information for Ontario Health. If you have any questions about this program or the information that we've discussed so far today. We're just going to go right into Module 2 here. Again, I just want to save the discussion for the end. But now we'll be sort of spending a bit more detail on the FIT itself. So for patients that are eligible for screening, these are people that again are average risk but never been screened, or their FIT was performed more than 2 years ago, or they had a colonoscopy for screening more than 10 years ago, or that colonoscopy found low risk findings, so hyperplastic polyps or low risk tubular adenomas that were less than 10 millimeters. These are all patients that could be screened with FIT. And so this is information from a study, again, looking at, and this is how some of the data that's supporting some of ColonCancerCheck's guidelines and recommendations. So this was a 10-year study done with the results recently published in 2025 on this ColonPrev study. The initial results helped sort of inform our understanding of FIT versus colonoscopy that was originally launched in 2019. And at that time, as I discussed earlier, the colon cancer-related mortality was comparable between one round of screening with FIT or colonoscopy, but the impact of colon cancer incidence was not clear because there are still more rounds of FIT that needed to be completed. So this looked at FIT every 2 years over a 10-year period versus the 1-year colonoscopy that would be done over that 10-year period. And again, there was higher participation among people that were offered FIT compared to colonoscopy. Again, screening, I know I'm being repetitive here, but a screening program is only successful if people participate. So more people participated in the FIT arm than the colonoscopy arm. And in terms of colon polyps, these were identified more commonly in the colonoscopy group than the FIT group. However, the risk of colon cancer incidence at 10 years was similar between the two groups. And the risk of colon cancer mortality was also similar between the two groups. So essentially, there was no risk, no harm or difference in major complications between the two groups because obviously the colonoscopy group underwent colonoscopy. In terms of the FIT group, the FIT positive patients underwent colonoscopy. So there were patients in both groups that underwent colonoscopy, and there was no major difference no difference in major complications. So colonoscopy is a safe exam. Complications are rare. I don't want people to leave this talk thinking that they have to avoid colonoscopy recommendations for the patients at any cost. But there are many patients that don't necessarily need to have a colonoscopy to have appropriate colon cancer screening. So we just talked about this. And this is just looking at organized fit screening in other jurisdictions. So both in California and the Netherlands, both of these studies show organized screening with fit led to both an increase in participation, decrease in mortality, and a decrease in colon cancer incidence. So fit screening programs are very effective. Other than that, what are the other reasons to use FIT? Well, again, better participation. Only people who are FIT positive are exposed to the risks of colonoscopies, likely more accessible to different types of patient population. We are lucky here in Toronto that we have fairly reasonable access to colonoscopy, but that's not necessarily the case in other places in Ontario or the world. It also, using FIT as a screening strategy frees up colonoscopy for other indications. We know that it is still a limited resource. It can be time consuming and costly. So we do have to ensure that we are using the endoscopy resources as appropriately as possible so that they are available when needed. And there's also a environmental and sustainability impact as well. In Ontario, we are monitoring colon cancer screening participation. There was a little bit of a dip in participation just coming out of COVID, but as you can see, the blue line here, things have stabilized. The target is 75%, so we are not there yet. What this suggests is that there are still many screen-eligible people out there that have not been screened, and part of these types of webinars and some of the outreach the team is doing is to try and reach these patients, reach their primary care teams, and ensure that we're doing everything we can to enhance participation in colon cancer screening. As I mentioned early in this talk, FIT is not recommended for anything other than screening. It's not validated for use in these types of scenarios. A negative FIT or a normal FIT test in a patient with symptoms does not necessarily mean that there's nothing bad going on, and potentially may just delay the decision to investigate symptoms or perform other assessments. So in terms of, just to quickly, I think this is all probably pretty, you guys are all familiar with this and do this well, but again, there will be delays in the FIT testing process if there are issues with how it's ordered. So if the information is inaccurate or incomplete, or if the patient doesn't understand what they need to do from their perspective, this will all impact how quickly the FIT is completed, how appropriate it is done, and then can delay the subsequent steps. So there are some changes to the FIT requisition. There is a replacement checkbox for patients with lost, damaged, or never received kits. This will need to be checked off if you're reordering it. There is a section here if patients prefer to have their FIT kit mailed to a different address than their residence. But just so you know, kits cannot be mailed outside of Ontario. So essentially, this is centralized in terms of distribution. There are a number of reasons for this. The reason we're talking about this is that many people wonder why FIT kits cannot be kept in the offices like the previous FOBT tests were. But what we found with the centralized distribution is that there's less variation in errors that lead to rejected tests. The tests we can monitor, ensure that they are being done in the appropriate patients, and these devices have limited shelf life, and the lab makes sure that the kits that are mailed out have at least a 6-month lag time before they expire. So there are a number of logistic reasons why this is being centrally distributed. We talked about this, so I'm just going to fly through this, but essentially the accuracy of the information will lead to a better process for both the lab and the patient. You guys know already that this is done at home, requires only one sample, and unlike the FOBT, there's no dietary or medication changes that are required. For patients, they have to make sure that they should check the label for accuracy, their name, date of birth. They have to clearly record the collection date on the FIT device. If this is not clear or not completed, then the kit will not be processed. And then the stool test is completed, and then it could either be mailed back or dropped off at any Rexall location, which is a change as well from before. We're trying to encourage patients to complete and return the FIT within 2 weeks of receiving it, and ideally within 2 days of completing the test at home. So I think I briefly mentioned this earlier, but for FIT tests that are invalid or rejected by the lab, you will not need to reorder or resend a new requisition. This will automatically be sent. A new kit will automatically be sent to the patients, and you will be notified by the lab through the result report. So you'll get a result saying it's invalid, and there's a note on that saying that a new kit is being sent to the patient. Stool collection, remind your patients to drag the stick across the poop until the groups are fully covered. There's a green check mark for appropriate, and there's either too much or too little, which can impact whether the test is valid or invalid. Once it's put back into the tube, it should be twisted closed. This is different from the snap closure that was previously, and hopefully will improve the quality and durability of the test without reducing the rejections in valid results. Again, the specimen collection date is very important, so the patient needs to complete this to ensure that the test is processed appropriately. In terms of FIT return and result reporting, so patients should mail or drop off their test as soon as possible, as soon as it's complete, ideally within 2 days if possible. The return methods, there is a change, so drop off at any Rexall location. This will hopefully be a little bit more convenient, as the Rexall locations typically are open longer hours than most of the lab drop-off locations that are currently being offered. And then they can also mail it back via Canada Post. So the results are going to be one of 3 things: invalid result or rejected device. In this case, a new FIT will be automatically sent to the patient. FIT will be normal, in which case they should have a repeat FIT test in 2 years. And it could be abnormal, in which case the patient should be referred as quickly as possible for a colonoscopy, The benchmark time for referral to colonoscopy is 2 weeks, and ideally colonoscopy should be performed within 8 weeks of the abnormal result. In the case of a positive FIT test, do not request a repeat FIT. The requisition will be rejected. So again, all FIT results will be available through OLIS. You will also need to have a direct method to receive FIT results. Currently, fax is the default. And the results are going to be, or rejections will be normal, abnormal, invalid, or rejected. For normal, this is the report you will get. So result normal, rescreen your patient with FIT in 2 years if they remain eligible. For abnormal, it will be reported as abnormal, and then there will be a recommendation to refer for colonoscopy as soon as possible, ideally within 2 weeks of the abnormal result. The result could be rejected, and in which case this would be seen when your patient returns the FIT test after the 12-month requisition expiry date. And this is a scenario where they would need a new FIT requisition if the patient is still eligible and appropriate to be screened. And then invalid, the specimen collection date was missing or could not be read, could be one of the reasons. And here, this is a situation where a new FIT kit will be automatically sent to the patient, and you will just be notified about it. Okay, so one quick case study here. So Anna is 64 years old and has recently completed a FIT. Anna's FIT comes back as abnormal. So she calls you and mentions that the FIT was completed 1 day after having a tooth removed by the dentist, and she would like to repeat the FIT. Well, what should you do and why? Complete another FIT requisition for Anna, refer Anna for a flexible sigmoidoscopy, counsel Anna on the importance of a follow-up colonoscopy, and refer her promptly for colonoscopy, or none of the above. Hopefully, you guys would all pick C. Most FIT abnormal tests are, there isn't a reason for them. Usually it's lower GI, so a dental procedure should really not impact the FIT positivity. And so this person, rather than having another FIT test, should actually be referred for a colonoscopy. So this is very important. Abnormal FIT. There's a number of reasons why patients can have abnormal FIT results. I tell patients that there are several reasons why the FIT is positive, most of which are not worrisome, but there are a couple of important things that should not be missed. Obviously, one is colon cancer. The other one is colon polyps. But we don't know which one it is unless we confirm with the colonoscopy. So that's the reason patients should have a colonoscopy. Is the worst case scenarios. This is a colon cancer, and we want to identify it as early as possible. So the target time for colonoscopy after an abnormal FIT is 8 weeks. The target time for referral for a colonoscopy after an abnormal FIT is 14 days or 2 weeks. And if you think about it, the colonoscopy is probably the hardest part to arrange. Patients need time to arrange the procedure. They need to take time off work. They need to decide when they want to prepare for the colonoscopy. They need to have a ride home. So some of this is dependent on scheduling and availability. Getting that referral in for a colonoscopy as quickly as possible maximizes the flexibility and still allows the procedure to be done within 8 weeks. So the longer it takes to send out the referral, the less leeway and flexibility there is for the colonoscopy to be arranged.
And I want to congratulate all of you, because actually we were not making that threshold as of last year, and we spoke about this in our meetings as well as in our letters out to you, and those numbers have significantly improved. So personally, as I do this, as soon as I get the result, I'm making the referral. There's no point in sitting on it. You do want to talk to the patient, of course, and warn them. We have to do that. But please don't delay on this. I know your inboxes are insanely full, and I get that. But recognize that these people are much higher risk of colon cancer than the regular population. So not delaying is pretty important.
Perfect segue, Dr. Kaplan. So this is data for Ontario, and what we can see here in so there are three bars here. There's the light blue, there's dark blue, and then there's the purple. And the light blue is the time it takes from abnormal result to the referral to the colonoscopy, and that is above the target of 14 days. This is again in Ontario. So as a province, we are not meeting that as of Q3. And then the dark blue is a referral to colonoscopy. And then the purple is abnormal result to colonoscopy. So what you can see is that despite that, the colonoscopy is still being completed within the target time. And so overall, the benchmark from abnormal result to colonoscopy is still meeting the targets. However, within our region, which is where most of you work, we are doing quite well. So we are meeting that referral target of 2 weeks. And what that does is it actually translates into improvement in the colonoscopy time as well. So again, it gives a lot of flexibility for the colonoscopy to be scheduled and arranged. And so what we're seeing is that we are also doing better than the province in terms of getting the colonoscopy done within a timely manner. So our wait time from abnormal result to colonoscopy is 47 days, which is below the provincial average. So thank you for doing amazing work in this regard. It's definitely, these are, as I mentioned earlier, this is a performance indicator, and we monitor this, we track this, we intervene when necessary. But when you guys are doing amazing, we congratulate you. So in terms of positive colonoscopies, they are likely to be slightly more complex. They are, as I mentioned, higher yield, so more likely to find advanced polyps, potentially cancers. So they require more expertise, time, and resources. So they should be referred to facilities that perform high quality colonoscopies and have the resources to support the interventions that may be required. So in our region, we are pushing them to be referred to one of our 4 sites, so Oak Valley Health, South Lake, Stevenson Memorial, or Mackenzie Health. The reason being is that also in the case of a diagnosis of colon cancer, there should be a pathway or mechanism for these facilities to expedite the next steps, referral to surgical oncology, staging, scans, blood tests, all of those things. So that's important. We are aware that with these changes, the number of FIT tests that are going to be requested are going to go up. As a result, the number of FIT positive tests are going to go up, and the requests for colonoscopies are going to go up. So as part of this program, we have also been working with the facilities to ensure they have strategies in place to accommodate to have capacity to accommodate these requests and still, again, maintain the benchmark target times and the performance that we just talked about. I'm just going to spend a few minutes here on surveillance recommendations, and then hopefully we have some time for questions. So we're almost done. Thank you for persisting through so far. So this is primarily going to be, hopefully fed back through the endoscopy recommendations after the procedure is complete. But it's important for you to know because you may get some of these questions from your patients. After a colonoscopy is complete, what is next? What is the most appropriate next screening test and when? So for colonoscopy that was completely normal, or had very low risk hyperplastic polyps, the next best test is a FIT test, and that can be done in 10 years. So these are patients that are, again, will be for average risk patients. If a colonoscopy reveals low risk adenomas, again, these are tubular adenomas that are less than 10 millimeters in size. This is also considered a low risk colonoscopy, and they can also have a FIT test, but this would be done in 5 years. All of the other findings there are much higher risk findings, and these will all be in the surveillance colonoscopy program. So essentially, the important thing here is that there are some indications for a FIT as a surveillance test after a low risk colonoscopy for whatever reason the colonoscopy was done. So again, this does not apply to people that have another reason for increased risk screening. So example, family history that we've talked about. So again, colonoscopy is done for any reason, FIT positive, symptomatic, primary screening. If they have no polyps or polyps that are not screen relevant, again, such as hyperplastic polyps, then they can have a repeat screening with a FIT in 10 years. So again, if a patient has a FIT positive test, then they're referred for a colonoscopy. The colonoscopy is normal. They don't need to have a FIT test in 2 years. If it was a high quality colonoscopy, they can go back to FIT, but it would be done in 10 years. That's the average risk pathway. And very similarly for low risk adenomas, they can go to a FIT test, but it would be 5 years after, not 2 years and not 10 years. And for any other high risk lesion, they would have a colonoscopy, and this should be appropriately recommended by the endoscopist. Surveillance recommendations evolve. So, the last time your patient had a colonoscopy, if it was 10 years ago, the recommendation at that time may be outdated now. And there may be other factors that may not be captured in the surveillance recommendation. So the main one would be colonoscopy quality. If the endoscopist was not happy with the quality, then they may recommend a repeat colonoscopy rather than a FIT test, or they may recommend a different interval for the next test because of that. So, and if you are referring to a different center or site or physician, it's probably helpful to provide the previous colonoscopy and pathology report if you have them, to allow that person to have a better idea of what to do and when to arrange their next test as well. So I'm going to stop here. This is a QR code to provide evaluation or feedback on this presentation, suggestions for improvement for me as well. For future webinars, and happy to take any questions now. Thank you for joining and sharing your Wednesday evening with us.
Thank you very much. So there's also in the chat, there's also a evaluation form. So there's two questions so far that have come in. The first one is, what would be your approach to a patient who is screening colonoscopy eligible, for instance, a first-degree relative CRC at age 52, but declines colonoscopy? Would you offer a FIT? Would you give up? What would you do?
That's a great question. I think we don't really have any guidelines or recommendations for that. I think in that circumstance, a FIT is better than nothing. And if they're dead set on not having a colonoscopy, as long as they understand that that is not the best or the guideline recommendation or the evidence-based recommendation, I would still offer a FIT as a better option than doing nothing and allowing them to not be screened at all.
Yeah, and of course, the question would be, what happens if the FIT is positive? Are they going to go for a colonoscopy anyhow after refusing it up front? The other thing I would just suggest is, please make sure that you put this in your chart in writing. And I would actually send a patient like this actually a letter saying exactly what's happened, because the last thing you want is someone to say, he said, she said, and the role, you didn't tell me this was important. So this is the kind of very high risk person that gets us in trouble because of communication issues. So please document well. And what I personally do in scenarios like this, which is anything that's off the beaten path, is I'll actually write the patient a letter with my concerns. It's amazing how that changes their behavior.
The
The
other, I
next,
mean, I'll change one other thing. The other thing you can do is actually, if they're willing, just send them for a consult with one of us, to have a discussion as well, um, and perhaps just having a bit more information about the procedure and 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 addressing their concerns or fears about it may be of benefit, but it also protects you, and has a second sort of person have a further discussion with them as well.
and that assumes, of course, that you've had the conversation with them, which I'm sure you have. Here's the whole concept of motivational communication, right? Trying to understand what the person's thoughts are, what their barriers are, and trying to understand what their concerns are so we can potentially answer them and solve them. Sometimes they just need to be heard on their concerns. The next question is, if someone hasn't completed their fit test within the year, will the primary care practitioner be informed? And do they have to resend the requisition or will it be reset for them?
So my understanding is that, if they don't have it completed, I don't believe there is a mechanism for you to be notified. I think that that would hopefully be in part of your own, whatever system you have in following up, on complete or incompleted requisitions and tests that you would find out. But I don't believe there is a mechanism of from ColonCancerCheck of notifying you that it's not been completed.
Yes, I wasn't 100% sure about that either. I do know that at 2 months, if they haven't sent one, and they get a reminder letter with all the encouragement and so on that should come with that. And over the last years, when the tests that have been sent out have become stale data, they've expired. I will often get a letter from the lab saying that the test is expired and you have to redo it, but we'd have to resend a test to the lab. That was to Life Lab. So I think it'll probably end up being the same for ILC, but I guess we'll see on that. It's a really good question. The next question was, is there any difference in follow-up for similar sized colon polyps between tubular adenoma and serrated sessile ones?
Yeah, it's a good question. I would say the sessile serrated adenomas are a category of polyps. So usually in my practice for sessile serrated adenomas, I will recommend a follow-up colonoscopy, rather than moving to a FIT test. So so they would not fall under the FIT 5-year FIT surveillance guideline.
Move to the higher risk adenoma
Yeah,
group, right? Yeah.
correct.
So that's basically, you're talking about low risk adenomas, which actually don't really infer a higher risk colon cancer down the road, and the higher risk has a graded increased risk depending on the type of adenoma.
That
Brianne has also put in the chat something about the 12 months. So I'm trying to read it. It's very small, Brianna, but you'll be notified
That's
by
okay.
ICL. You
Yeah,
go
I
ahead.
just wanted to clarify on
Yeah.
the CCC Hub website, there is a frequently asked question document that likely will have a lot of answers. And one of them is that yes, ICL will notify PCP that the fit kit has expired.
Oh,
And they
that's
have,
great.
and they'll have to, do they have to send a requisition again, or it's automatically going to happen?
No, a new requisition would be required after 12 months.
Okay. Yeah. So it's a little bit of work for us, unfortunately, in the primary care realm. So next question is, Vishal, for people who are higher risk for that family history under 60 or two people with previous history of colorectal cancer, what do they write on their referral to get them into that fast track situation like the fit happens?
So there's no number one, there's no benchmark or target like there is for fit. Even what I would say is that even in that circumstance, the fit probably is more high yield and more of a priority, a fit positive compared to sort of a patient that is being screened for family history. Regardless, I think having as much detail about the family history is very important for me. So if I get a referral that says family history, to me, I've seen that could mean anything from a cousin, like a third cousin with colon cancer, or maybe colon cancer of an unknown age, to sort of a father with colon cancer at the age of 50. It could compass any of those things. So having as much detail really will allow me to say, okay, this one needs to come in as quickly as possible. So I would say more information, the better.
If that appears to be our questions, I'll make two other points then. The first, of course, is that one of Vishal's first slides was the increased risk of lung cancer and the higher numbers of lung cancer than colon cancer. So I'll just put a little plea in there to recognize that we now do have lung cancer screening in the central region at Southlake. And if you have any questions about that, please reach out to me. My email has been put into the chat. The second is this is accredited, so you're going to be getting you'll be doing your post workshop review, and we'll be sending you a credit letter in the email after that. So last
Yeah.
chance for any questions or comments.
I would just add one more thing, regarding the patients that are hesitant to go through screening or a colonoscopy. This is one of the few areas where we can actually intervene and do something to prevent. A lot of the screening tests are looking for cancer at an early stage, but in colon cancer screening, we actually are also looking for polyps, which, when we intervene and remove them, actually prevent colon cancer. So I think for many patients who are just afraid of knowing and finding out a bad diagnosis, it's important for them to understand that that's not necessarily the case, and undergoing a colonoscopy or a test may actually prevent them from getting the diagnosis that they're afraid of hearing about or being diagnosed with.
Yeah, super important whole point there is we can actually prevent the disease. And we're moving along that lines for HPV as well. By diagnosing the infection, we can see people who are higher risk and evaluate more quickly. Another question did come in, so thanks, Andrea. Father diagnosed with colon cancer, but over the age of 60. Maternal grandfather, colon cancer over the age of 60. Mother has polyps. So are the children considered high risk or average risk? And the father surgeon, by the way, recommended she start a colonoscopy at age 40.
Yeah, so you're going to get a lot of
Yeah.
ambiguity. These changes are going to make some people uncomfortable for sure. But technically, based on what you've identified there, that person would be in the average risk profile and does not need to, based on the new guidelines, does not need to go into colonoscopy screening. Now, you are all going to get these discussions. You're going to get some patients that are extremely colonoscopy averse, and then there are some that are so anxious about seeing their family members go through this that are going to want to have a colonoscopy. Again, these recommendations are population wide, but you have a patient in front of you, and you have to have that discussion. You have to do what you feel is right for that patient. So there are some that are going to be very adamant or feel strongly about a colonoscopy, and that doesn't mean you're not allowed to order it, and that doesn't mean that you're doing something wrong. But I think the key message here is that the more people that are offered FIT, the more people are likely to do it, and the more people are going to be screened, and that's the most important thing from a population-based level, that they're more likely to do FIT, and if we're able to at least screen people with FIT, more people with FIT, then we're going to be better off in terms of colon cancer detection and prevention.
Right. So if we do the people who are higher risk, we're going to have a higher yield, which is important for the total number across the entire province with under resourced as we are. But we've also learned today about the overall risk of having colon cancer. So none of it's zero, Andrea, right? So none of it's zero. So therefore, nope, we can't ever say you don't have it for sure. We can say that your risk is the same as the regular population. And if you still wanted to have that conversation about a colonoscopy with this 1 in 1,000 risk of complications and so on, so be it. But you got a little bit of information to back that up, that based on the current recommendations, you're considered an average risk person to this particular person, and you probably just need to have a fit. And if that's positive, obviously we'll go from there. So that's sort of the answer to that, but it's going to be a conversation, as most of these things on the edge are going to be.
And remember, these a lot of these colonoscopies are once every 10 years. In that time, someone's going to have 5 fits, and there's going to be plenty of opportunities to potentially identify opportunities to do colonoscopy if needed. So so that's the important thing as well. It's not one fit versus one colonoscopy.
And the next question that's come up here, so thanks for these late questions, guys. And it's going to be part of this change in the recommendations. If there's a discordance between the current recommendations for post-polypectomy surveillance versus the endoscopist suggestions, what do you default to, the endoscopist or the new recommendations based on CCO?
Great
Tough
question.
place to put you in. I'm sorry.
Yes. Depends on who the endoscopist is. No.
No.
You have every right to kind of push back and say, the guidelines suggest this, and I get that all the time. Some you guys are so good at looking at the results sometimes before I even get to them, and I'll get a note back saying, you recommended 5 years, but the pathology shows this. Do you think you should do it in 3 years? And I have no problems with that. I love it. And so the same thing with the opposite. So if someone recommends one thing and then it's discordant with the new guidelines, there's possibly they don't know about them, or perhaps they have another reason for recommending what they did. So I think it's completely reasonable to send a note back saying, can you clarify based on the current guidelines? If someone sent me that letter, I would have no problems with that.
Yeah, all about communication, right? So that's how we have to stay safe and keep our patients safe. All right, so no last questions. Any other messages from our team? Well, with that in mind, I'd again really like to thank Dr. Patel for going through this quite a bit of information, going through it quite clearly and making quite clear recommendations, I think, to all of us. I hope it's all clear to all of you. Don't hesitate to reach out to us if you have any questions about that. And otherwise, I'll give you 7 minutes back of your life and we'll finish a little bit early. So thank you all for joining, and it's been a pleasure.
Thank you very much.